And now we're happy to have a panel discussion. I would like to first introduce our panel moderator, Tobias Alfvén, who is a pediatrician and professor in global child health at Karolinska Institutet. And I hand over to you.
Thanks so much, Morten and Olivia, and thanks to everybody for this morning. I thought this was going to be good, but all the presentations really showing what's happening globally, where you started, Joy, and then moving to globally about what we all do together. And as we heard from a couple of presentations, this is not about I search, this is about we search. And I think now after this individual presentations, we move to the we, how we as a panel together with all of you can think together for an hour, how we can move on. Because we have all been to many nice presentations and everybody agrees this is important, this is something we should do. And then we go back and we do what we do all the days. As we heard from Ylva, we're very good at doing what we do all the day, right? Because we just continue. So in 1 hour, how can we take the first steps to move on? That when we meet in 5 years' time, these curves are different, and we have been part of making that difference. That's a big task for an hour, but with this wonderful panel, again, you have all been introduced, but I again would like to introduce you just to show what kind of expertise we have. Joy Lawn, professor at the London School of Hygiene and Tropical Medicine, a pediatrician, and with over 30 years of experience of perinatal epidemiology, and especially in sub-Saharan Africa. Diane Gashumba, the Rwandan ambassador to Sweden and all Nordic countries, and also a pediatrician, which I think is so nice, and a former Minister of Health in Rwanda. And we saw so much of what you're doing in Rwanda, and that's really amazing to see. And for example, this about community health workers. We have discussed it for such a long time. How do we get them to stay? And now it seems like you have found a sustainable system and you create them to entrepreneurs so they can sustain themselves. And then Ashish KC, Associate Professor and Senior Researcher in Global Neonatology in Gothenburg, and previous also technical advisor for a long time at UNICEF in Nepal. So you have a lot of experience from the field where you really have been working on this, how to implement. And then Agnes Linnér, neonatologist and postdoc research in global neonatology here at Karolinska Hospital and the Institute. What a wonderful panel. I think we give them a big applaud. So what I thought, we move back a bit to the what, because we need to know what we want to do, but we have discussed that for part of it, so we take a couple of questions about that, but then we move to the how, and how we as Sweden can contribute, as we have in the title, how can Sweden contribute to global neonatal research? And then important for all of you, you will be invited for questions, and everybody online, please use the Menti, or if you have something already here, use the Menti so we get the questions. Olivia is sitting and looking at the chat, and if we have something, so we get the discussion, and then we open up so all of you can be part of this. And we just have an hour, and then we will continue afterwards during the lunch break. But it's there. Perfect. I like that. It's good to be proactive. So the Menti number is 13497011. So please have a look at that and go to the Menti. So if you have your question in your mind, you can immediately write that down. But we saw a lot of nice and important presentation about different ideas and also setting the scene as you did, Joy. And if we move back now to the what, we know that resources are limited. A lot of money is spent on this, but not enough. And in some parts, hardly anything. What should the focus be? What's the what? Joy, if we move back to you from your first presentation, you alluded to that and you spoke quite a lot of it, but if you need to decide one thing, what should we focus on?
Thank you for that easy starter question, Tobias. So I think that we all have one common goal, which is we want to see that every newborn everywhere gets the same chance to survive, whatever the context, whatever the system. And I think to do that, we need to have the end in mind, that we want every country to be able to have their own system that delivers that at birth with your 3 minutes and everything else that you need, and with the neonatal care. And so, I don't know, has anybody heard of the diagonal approach? Okay, you need to go and read about Mexico health system transformation, one of the early Lancet country series. So, you know, whether it's horizontal health system strengthening or research, we all tend to focus on one thing. And we actually need all of us to do that one thing well. But if what happens is we have lots of one things, either they're kind of vertical things or horizontal things. But what we need is all of us to think of a diagonal way where our little bits all come together to make that package that actually works. Because if we drop one part of the package but the whole rest is missing, it will fail. And we know that for newborns. Newborns don't just need one thing. They need, you know, a sick preterm newborn probably needs 16 devices. They need, you know, a high ratio of nurses. They need space, and they totally need their family empowered. So if all of us could think diagonal, even when I'm doing like my one thing, how does it help the country I'm in, whichever it is, to move further forward? Not just do that one thing, but move to having that package. And for example, if it's a CPAP device, I do not care what the brand is, but we can't have people using improvised devices. And then we need to have less is more. If we have 10 people competing for brands, we will actually not help people. We actually want to have 2 or 3 that work, train everybody on 2 or 3 and have all the parts. So I think all of us, whatever, if that's a concrete example of a diagonal approach, if we're moving forward on CPAP, let's think, how will this help this to get to everybody and be sustained, not how do I get my paper on it, I'm afraid. So if we wanted one thing, I would say that all of us work towards a common goal where the context we're in is able to build towards their own target, which is to make more happen, not just go backwards.
Thank you so much, Joy. And looking at that, and I think that's very important. That's what we saw this morning, because now we saw different pieces. We saw the 3 minutes, we saw the LMA, we saw the IKMC, and individual projects. We need to be good at something, but then we need to link that.
Yeah.
And I think that Lancet paper from Mexico about the diagonal approach, thinking about that, it's not either horizontal or vertical, but you need to work together.
Yeah, and maybe can I just add to that too, the other thing that they did in Mexico was they forced the funders to do that. And that's your success in Rwanda. You force the funders to add the next step to your health system package, not just drop one thing from the sky here.
And I think that's a perfect segue to you, Diane. And what do you think? What's the what? What should we focus on?
I would focus on more on global health in reality, because I think countries just do public health. Most of the countries, especially developed countries, they focus on what is happening within their boundaries. We really don't do global health. If I'm not diplomatic, I would even say we don't care about what is happening in other countries. I don't think we really care about these babies that are dying out of our boundaries. So I would focus on others. And it's a win-win, depending on what a professor wants to achieve. He can achieve what he wants to achieve for himself, for his own country, but also helping and sharing what he has and others don't have. Before coming here, you spoke to 5 PhD holders who trained here in Sweden, and then I asked them, how did you choose your topic? What was the rationale? What motivated you to choose this topic? And all of them, they said, 2 of them said to grow in my career for more, to get more career opportunities. And one said for better salary. And another one said, it's because I could find a professor in Sweden who was interested in this topic. So this picture, I can ask 100 of them, and I think I would get the same answers. So no one really chose a topic because he cares about the issues that are in country, because he wanted to go back and change the system or contribute. So it's really, that's my answer to this. So I think we need to focus on global health in reality, not in theory.
And I think that's great that you raised that, Dan. That is really, that's why we're here. But I think it's, again, very easy to forget about that. You start with that when you're a student, but then you dug down into applications and the system, and you forget about the large picture. And I think that's important for all of us, that we really think about that. Why are we here? What do we want to do? And how can we convene that message to others, which we'll come to. So that's excellent. Thanks so much. And from that, moving to your experiences, and I think your presentation was very much about this, but again, what's the what?
Yeah. So I'll take this analogy just into the human history. So 75,000 years back, in the chain of the animal kingdom, we were in the middle. We had a cognitive revolution, and we came up to the top. Until now, we had 3 revolutions taking place in human life. Why is that taking place? Why we aren't braver or faster than the leopard, but we are there because we are cooperating with each other. And that one cognitive revolution that took place 5,000 years ago just brought man, the human, to the top of the animal chain. And I think that's what is required, the cooperations. Of this room, the knowledge that we have, even 1% of this knowledge is translated to other actors, media, research group, politician. We will be flooded with funds and our civil movement. And I think that's what's required right now. As we know that there's a good example that in Sweden, the mortality that reduced newborn is not due to physician. Event and intervention in midwives were strengthened, reduced the mortality for newborns. And I think that's the cooperation of interdisciplinary reality that's required right now, is that we move not only within our profession, beyond our profession to different actors. And those actors can be media, pressure groups, or other disciplines who are and beyond our limit. And that's what I really like about you, Tobias, is that we might do the same thing, but we might want to do the same thing to a different person. And that's something that's required.
Thanks so much again, raising that, and I think that's important. We're many different professions here. We work on this together, and I think we need to be even broader to include, and was it you, Joy, who said that the technicians, you need to love them, otherwise the machines will not work, and they're staying there in the graveyard. So I think we need to be open and work with others. And I can just say that it's so much easier to work with colleagues from the same profession and what you do all the days. But you need to be brave and actually try. And we have been trying to do that in environmental sciences and economics. It's so difficult. I understand half of what they say. And that's really, it's tough, but it's very important. Agnes, what about you? What's the what?
Yeah. So, I mean, the key thing for me, I was thinking of the picture that you showed, Joy, about all the machines, the machine graveyard. And to me, there's like a virtual idea graveyard. I've seen so many places where people have come with great ideas, clinical trials to conduct, and then some results are found, and sometimes no results are found, but nevertheless, then they go back home and nothing's changed really. And from my experience with the IKMC trial, obviously I'm super happy about the WHO recommendations, but really what between the recommendations and the practice really? Also coming back to the slide about how funding is distributed over like the ID. I don't remember the exact parts, but I remember the implementation part getting 3% or something of the budget. Yeah. And yeah, so what there? I think we need to be more patient. We shouldn't be patient in the way that we are happy about the way things are, because we're not happy about the way things are. But we should stay a bit longer, see how the new results can be used, implemented, and we should be perseverant. We should stay and implement and evaluate and try again, see what happens. If we implement one thing, maybe we have another effect coming from that change. So we should stay after we've finished with our trials. I think that is the key thing.
Extremely important and sometimes difficult, I would say, because very often it's that we get a grant, we do a study, and we publish, and we celebrate. We have champagne, New England Lancet, something like that. This is great. And then the grant is over, and you need another trial, and we move on. Yeah. And then nothing else happens. And how can we move from that? And I think that's a perfect segue to the how, because I think that's so important. So what I bring with you, I hope, the diagonal approach, that we need to focus on what we're good at, but at the same time working within the health system. And then to make global health real and not just a slogan, and then to work together, and then to stay on and continue, see that something starts to work. But it's not enough to have a trial, you need to get it implemented. Otherwise you get the, what did you call it? The virtual idea graveyard. And I think we have too many projects that are just a study and not more.
Yeah.
So I think that's very, very good ideas. And how do you bring that into reality? And then I would like, Diane, you're not only the global health ambassador, you're not only the ambassador to Sweden, but to all Nordic countries. And we work on global health issues differently in different Nordic countries. Is it something that you have seen in other Nordic countries that we should bring forward and say, look at Norway, look at Finland, look at Denmark, Iceland? I'm not sure. We should do it here. It's always good because Swedes, we're always wanting to compete and compare with our neighbors. What do you say?
Yeah,
Pastoral skills.
I'm a bad one, by the way, bad diplomat. Because, yeah, I think my background is taking much of my personality. So I always speak my mind. I was told an ambassador has to be. I'm not that kind. So I will pick the example of Finland because I happened to. I was in Finland this morning. So what I saw in Finland and what I've been discussing with the Finnish education institutions, they acknowledge that they have a shortage of skills. For example, they need nurses, they need midwives, and they want to outsource them in Africa. But we also need our nurses, but we need also their quality of education. Finland is at the top when it comes to quality education. So how is we sat together and we had an open dialogue. They need us, we need them. We don't need them, we don't want them to steal our nurses. They can do that because everybody is free to go wherever feels good and have a good salary and a good. But when it comes to Rwanda, maybe because of what we went through, the genocide, we have this level of patriotism. People, they come, they study, but they go back. They go back to serve their communities, which is a very positive value. But they also need this quality of education. They need this high level of standard of life that is in these Nordic countries. So we made a good deal. We told them, come, you train 1,000 nurses, you provide them with the high standard quality of education, and you take 30% of them. That's a good deal. Yeah. It's a good deal. We benefit, they benefit. That is a conversation I would like to have with Sweden. I know it's not easy to come and work here, for example, although you have a shortage of skills. I don't know where to start with this conversation with the Swedish government, with Swedish institutions. But Sweden has a lot to offer, and I want also to mention that Sweden was the first country to come in and support Rwanda after the genocide against the Tutsi. Last year we were celebrating 20 years of strong and a great partnership in education. With the SIDA and the University of Rwanda, we have a partnership with 17 universities, and we really got a lot from Sweden, and we are grateful. But if it was to restart, if we had to redo the same, I would say we need to do it in a more sustainable manner. Today, I would like to sit with all these alumni who trained here, these PhDs, master's degree, and ask them, what did you do for Rwanda? How did your thesis or PhD topic impacted lives of Rwandans? I don't know which kind of response I would get, but this is a dialogue I would like to have with all these universities and with the beneficiaries, and to plan ahead and say, yeah, today we are almost crying, there is a cut of budget, the government cut the budget, but my minister told me it actually was overdue. That was his answer. He was expecting this, so people should have prepared for this budget cut. You cannot get an aid for forever. It's not sustainable.
And that's this looking at impact, and I think that's great. And maybe that's a follow-up. That would be very nice. With all the Swedish universities, we have Kristina here in Gothenburg. I mean, you have been working a lot with universities in Rwanda, especially University of Rwanda. And again, to collect everybody, it can be a virtual meeting, but just, what's the impact? What have we learned? And follow up this. We have done a bit of that with a long-standing collaboration between Sweden and Uganda, between Karolinska and Makerere, to see what happened with all the PhD students. Where are they now? What's the impact they have had to show, and then again to build other systems. And you, Joy, you're familiar now to Sweden. You have been here as the opponent. You know what we're doing. What's your advice about how can we get our combined resources together, the team Sweden in global neonatology, to be best used for global health in real life and not just as a slogan?
Well, I must say it's such a privilege to come here and see you all. I mean, you're doing so many fantastic things already. I think a critical thing is for us to be smarter. And actually, Ashish talked about Jeremy Schiffman. Who's read Jeremy Schiffman's work? I think we need to understand the socio-political drivers of what makes global health an issue in different countries and what takes it off the agenda. I speak for a country where our overseas development aid got Borised badly. So I think we need to be smarter. And basically a lot of that is funding and perceptions and political drives. And we waste a lot of our energy in academia fighting on the wrong fronts. I'm sure you know the famous thing with Kissinger, who was the US Secretary of State, and he was asked, you've been a politician, a businessman, and an academic, which was worst? And he said, without hesitation, academia, because they fight with each other and over things that don't matter at all and have no impact on lives or money. So academia can have a big impact on lives and money. And I don't know how your academic credit system works here, but one of the kind of only okay things about the UK academic system is it's judged on ref cases, which are not, was your paper cited, it's did your paper save millions of lives. And actually the London School came out top in the UK ref case ranking the last time. And always in the past, their ref cases were on infectious diseases. For the first time, we had 3 neonatal ones in the top 20. So I think we have the opportunity to show something that other people can't show. Our research will impact deaths, survival, families, human capital, but we're rubbish at showing that. So if we want to change both funding and policy structures, Jeremy Schiffman has his, however you do it, your ideas, issues. I think of actors, narrative, and platform. But the economists have a much simpler thing. They say, who funds what and why? So who funds what and why? Whether that's overseas development aid. So I don't know, you may have missed this webinar we did on Tuesday, but I encourage you, it's live on YouTube already for catch-up and already had lots of catch-ups and will be in French. We looked at the ODA funding, who funds what and why, for the last 18 years for newborns and stillbirths. Nobody mentions stillbirths still. Why? It's not because it's a small burden, it's a big burden. It's not because it's not preventable, it is preventable. It's because there's nobody standing up speaking for it. It has no power at the table. Newborns, we're starting to have a little bit of power and voice at the table, but you know what Jeremy Schiffman said in his assessment for newborn health? The newborn guys are a small group who are all nice to each other, but they're far too nice. So I told Tobias said, it's a nice thing to be told you're too nice. I'm like, yeah, I love to be told I'm too nice, but it's hopeless for changing the world. Nice people do not change the world. It is a fact. But you know who can? Maybe we still need to be nice, but parents jolly well have a right to be out there and be angry. So this is happening in the UK at the moment. We have so many big shifts of parents complaining about maternity and neonatal stuff. And we completely fail to do this in global health. The women are not just nice to be there doing skin to skin. they should be in the media. And we tried to do this with Born Too Soon. So this is something we can do together. And we must do it together. We must do it for stillbirths as well. Because that was how did HIV get money? Who's read Peter Piot's autobiography? No time to lose. Sense of urgency, bring in all the different players. You have to work with the parliamentarians, women parliamentarians who've had a neonatal death or a stillbirth, parents. And you know what also? The UN was an impediment. So I don't know who's watching online, sorry. But the UN can actually see themselves as a gatekeeper to stop things sometimes. And that happened for HIV, and it also happens sometimes now. So we need to be much smarter. Who funds what and why? And the voices that actually matter are people whose kids have died or have been affected. And we need to be much smarter about getting them in the press. We also need to be much smarter about getting successful politicians in the press. So next week we hope to get the president of Tanzania. Her 2 grandchildren were born preterm. She's been putting some of her own money in. The government is putting in quite a lot of big money just in the last 6 months. Our aim is to get her in the media and then say, oh, look, only woman president in Africa. Look what she's doing. What about you guys? So we need to be much smarter, but we don't have enough people doing that. And, you know, we should play in the field that we're strong in with, you know, whatever you're good at, but also try to see how do we change the funding, because we won't get funding for research or for action if we only talk to each other.
So I bring forward the PMP, the parents and the parliamentarians, that we should be much stronger about and really talk to and show
and
what we do.
Power.
And people power, so PPPP, people power. That's great. We have the 4 Ps from this, and that's good. So people power, parents and parliamentarians. And then I think it's so important what you say, really show what we do. And just an example, one of my best friends complained for a long time about all the high taxes in Sweden. We didn't get anything for it. And then first delivery, difficult, his wife bleeding a lot and a child didn't breathing. And then afterwards, you know, and he was just, you know what happened? They just hit the button and it took 20 seconds and then everyone was there. And my mother, my wife, she's fine. And our daughter, she's fine. You know, this is unbelievable. Are you there all the time? All the nurses, all the doctors? Is this true? And I said, yes. Oh gosh, and he has not complained about taxes once for 10 years. So I really believe it's all about the stories, right? If you don't see it, you don't understand it. So that's excellent. We take the 4 Ps and the impact. And talking about impact, Agnes, what you did with your large immediate KMC study, that was actually having a study in a nice journal, but then also changing guidelines. And hopefully now colleagues are using this globally because you need to follow up. But what did you learn from, I mean, it's a long journey all this way. What did you learn from this and what's your advice to all of us? How can we not do the same thing, but what can we learn from what you learned?
Yeah, I think a key thing is obviously to know the clinical field, to know what is needed in terms of research questions. On the one hand, you should do what you're good at. As Ylva said, you get good at what you do. But on the other hand, I think we need more clinicians who are also a bit trained in research methodology in order to know how to design studies, how to plan them, and so forth. Also, we need funding, obviously. I mean, randomized clinical trials and the IKMC trial was really expensive. And without funding, it's really hard to get good data. You need people to be there, collect the data, and they need to be paid. Manpower is expensive. So I would say clinical researchers and good funding. Also, I think that clinicians and researchers should be more politically aware, really. I think, correct me if I'm wrong, Morten, but one of the things behind this seminar was that overnight, almost a while ago, global research budgets were cut just by changing the political governance in Sweden. So that's how fragile things are. And we need to be aware, and we need to get engaged politically as well. Otherwise, what can we do?
Again, No, so good and so important, and these two issues about again clinicians knowing what we're talking about, but having the research skills, so you can take it from just your idea when you're there. If you don't have that skill set as well, being a clinician and then having the research skills, then it's difficult to even get the questions and ask the right questions. And then we need to be more active in the field of we need more being better advocates for what we believe in. And that's Ashish. You have, I mean, you started your career in Nepal, very hands-on, and now you have been a successful researcher in Uppsala, now in Gothenburg, bringing this. What have you have seen different aspects of Sweden? What do you think? What have you learned, and what can we learn together from your journey through the Swedish academia system?
Yeah. So I have been transitioning with different groups, stakeholders of the community, and as a transition from one community of public health practitioner from being a physician and then being academia, we are living within our own bubbles, and we have our stories that we tell. For academia, we tell our stories in Lancet, New England journals, JAMA. That's our story. But are you telling the story to the right people at the right time? And I think that's key. So if you see the HIV movement that nothing was published so much highly in things. So first thing is that we need to get off our bubble, create that critical mass out of the bubble to public health practitioners, and those might not be only physicians. It can be media person, it can be civil society. And once you create that narrative, because that narrative is correct and true, because we know that if newborns survive, if they optimize their health, they're going to thrive well and support the society. I think that narrative hasn't been created, at least in Sweden. So first thing that gets cut whenever the government comes in is the development research. And the narrative we have set is that why would there be a pleasure of doing a research outside the country just to travel? That's wrong. Our narrative should be that we are trying to help the baby who will be born survive well and thrive well, optimizing human resources. And that's our fundamental thing, which we haven't set through. As Ulla mentioned, why anemia? Anemia, if these children are prevented, these are going to serve the nation and the world. So I think that narrative hasn't been. So we have our own bubble of our publication and our stories that we tell. But one of my mentors used to say that if you want to tell your story, try to convince your own grandmother. If she's convinced, then everyone is going to convince. And I think for that convincing, you don't need to publish in a high impact journal. And that's what I've learned over the years. Transition from different phase to different phase is that create a narrative in a very simple way that even a politician can do that. And I think there are two ways to do it. How? Second is that similar, and this is a fantastic work that we have done, Tobias, bringing all the Swedish newborn health researchers in a big forum. And I think inviting Joy as an advocate is I think, can we do similar for parliamentarians? Can we do similar for media in a very simple way? We tell our narrative, we tell our stories to our children, to our books in journals, but can we tell that in a SVT, in Dagon Hats every day? How do we tell our stories? We have our stories. This wisdom, as we say, is quite a wisdom which have made us at the top of our animal chain. How is that narrative going to be translated? And I think that's what we need to think through, going back that how can we tell them to the parliamentarians who are not going to cut the budget once there is a government who is who wants to have more into other areas. So yeah.
Thanks a lot. And I think this morning and the discussions have been so good, but something we have failed with, and now I look at Morten, it's actually we invited the minister responsible for overseas development aid. We invited his state secretary. We invited politicians from all parties in power in Sweden and the politicians responsible for ODA issues. They were all too busy with something else. Just come here and meet us for 15 minutes. We say we have world-leading researchers and Joy Lawn is here and everybody, oh, sorry, too much to do. So we did not manage that narrative. I mean, they should have been here. They should have been listening to this, and we need to find something else. And I think it's a failure, and we have not managed to do the homework good enough. So.
Just to add on to that, I think our narrative should have been created using, and I think because they wouldn't like to come to a forum and defend themselves, I think what would be helpful would be that hearing them on why did they do the funding, and then trying to be more of a partner, because that's what I think we have been doing, is creating champions.
Yeah.
And if we create a champion of critical mass within media, within civil society, within parliamentarians, I think, as I said, this wisdom, if 1% of them is trickled down in a very large seven-ska manner, I think we are going to achieve as an collective audience. And it's not only for us, for next generation of leaders that we are going to create.
I think that's excellent. We need to build on it. And I mean, we should not just say we didn't manage. This time we can do differently, but we need to think differently. And I think that's a perfect way to open up for everybody. Do we have anything online? First, let's see if we have something online.
Yes, okay.
And then I promise, because I think it's so important. We also have colleagues online, and if we have anything online.
Exactly. Let me see here. So here is a question. Oh, no, I just turned it down again. Let me see. Playing the right keys with the iPad. This is a question for Joy. How can we be better to communicate and make sure our research questions align with the bigger package that you spoke of? And I think many of your speeches has been about this. How can we communicate to aim for the same goal?
I hear two questions there. One is what's the right question and how to ask it, and then the other is how to communicate afterwards. So I think the right question is that, you have to start from what the burden is and what you're able to ask. Do people know those Japanese overlapping circles, 4 overlapping circles, ikigai? So really, I always say this to PhD students when they start. You're looking for something in the circle in the middle. What does the world need? What actually are you good at? The world may need something, but if you haven't got a clue, don't try. What can you be paid to do? So this reflects what you said about people. And then it's also what is actually answerable. And to be answerable, you also need some understanding of evaluation design. And as we move forward into bigger impact systems packages, it's not all one serum rhubarb versus other serum rhubarb. It's going to be more complex evaluation. On the communication, I think we fail to help people to communicate better. And interestingly, Ashish and I first worked together in Save the Children when he was in Nepal, and I was with Save the Children with a very large Gates-funded initiative for the first kind of 10 years of newborn health globally. I learned far more from Save the Children, actually country program officers talking to parliamentarians, than I ever learned in academia. I think we need to do a better job of helping people to communicate to their grandmother, to parliamentarians, and because we teach people to do a, science talk, which is an important skill, but it's very different to then, make the case to effect large-scale change. I just want to quickly reflect on the parliamentarian issue. So parliamentarians never leave their power zone. You ask them to come here, they'll only come here if they're going to win votes for it. So you have to go to them. So actually this is another thing that I've learned a lot in different, like Uganda has a woman parliamentarians group. You have the only country with the majority women parliamentarians. How do we mobilize them to have their voice? But in the UK, we have really very mixed parliamentarians, less said the better. But we do have an international health parliamentarian group that cuts across all parties. And they convene on different topics. They used to only do TB, malaria, family planning, but we've managed to get them to branch out a little bit. Stillbirths, hope to do newborns. And that's a much better way because, especially if you get them across parties, the US also does this, right? I've spoken to the US guys and the UK guys. So, you won't get them to come here. You have to go to them. You have to do it on an evening with drinks. You have to have some famous person, blah, blah. You have to have them say something, and then they don't come, they hate experts. They're not going to come to listen to experts. So anyway, just some thoughts there.
I think that's great. We have actually a group of parliamentarians that we can, and they discuss issues, not really like this, but we will teach them to also discuss this. So that's great. We have a couple of questions here as well. Sanna started and then...
Working? Yeah, okay. So we talked a lot about like funding, driving like global funding to global health in the right direction. I have one thing that I'm thinking a lot about, but I've been to many conferences now worldwide, and we talk about global neonatal research, but when you come to the conferences, there is very few things focusing on global neonatal research at the conferences. I feel sometimes that you are a small little group meeting in some corner, and I wonder a bit if you have some ideas how big pediatric conferences around the world, how they can start reflecting the global burden of disease, and as most of the neonates die in low resource settings, I think the conferences should be at least 50% about that. Do you have any ideas on how we can push conferences, like research conferences, in that direction?
What a good question. I think Ashish wanted to start.
Yeah.
Say something that just happened in Rome, because big shift.
I think so. I've been part of some of the global conferences, and I think the problem with this conference are there are two types. One is a clinical conference, where the clinicians come in and discuss on their findings and then try to elaborate. And the other one is a public health conference on maternal and newborn health. And I think the problem with these ones are that these conferences only have a uniform kind of an audience. So these are more clinicians, more public health. So we don't bring parliamentarians. As I said, until unless we diversify the group, the actors, no one is going to hear about it. Until unless a common people thinks that newborn health is an agenda to be pushed, the politician is never going to hear about it, because he or she is going to vote to the politician who is going to take up that thing. So there's a whole issue of this conference where it needs to be more diversified. There is now a big talk on decolonization of these workshops and conferences, where it's more go to places where it is really required in terms of research and funding. So yeah.
Maybe just to quickly say, who was at Jen's? Okay, first time. Half the opening plenary, global health. 3 major global health sections. How did we get that? We got it because actually the funders who were bringing people in pressurized the 3 presidents, who said, oh yeah, we'd love to do that, of course. So, I think it's right that there are lots of different types of meetings. So, for example, pediatric academic societies, 5 years ago, we had great global health stuff, and it's absolutely nothing now. And that was because the senior person, Alfvén found it. So I think you need to find leaders, like find the presidents, because quite often they're like politicians, they also want to look good. Presidents of these, there's 3 presidents of Gen, all of them wanted to look good. And then all of them stood up afterwards, yeah, we look great. So now we're having them write a statement. There's going to be a joint statement, which is coming out of Gen's, which says, all neonatal societies should do this, future meetings should have major stuff on it, we should follow up. They should fund a certain percentage of not just that it should be abstracts on global health, it should be people from the global south, please, who are funded to come and do them. So I think when that statement comes out, it should be published in lots of different journals. Ola Sagstad is leading the way. He's going to have it in neonatology. We get that in lots of journals. Then we need to make a noise. Then next time you go to a meeting, you'll get a committee thing before. You need to say, here's this statement. Why has your meeting got no global health? Should have global health in the opening. Should have global health on the way through. You should have scholarships for people from low and middle income countries. The UK Neonatal Society is making their virtual registration free for low and middle income countries. Hot Topics is a rip-off. Nobody can do that from low-income countries. So we need to complain to people. Like, I sent them an email. I'll probably put it on Twitter, except I don't tweet anymore since it became X, because I object to them. But we need to call out, like we called out manals. So manals became unacceptable. We need to make it unacceptable to have large research setting presentations and agendas where we have nothing for 98% of the burden. It's not acceptable.
Thanks so much, and I think that's great. It's something that could be nice to also write about in Sweden, in Swedish conferences. I think we had 3 questions here. We take all of them at once, and then we take a round to answer the questions. Ola. Oh, Thomas. Yeah, quick.
Okay,
Thomas,
a quick question then. Like, we're talking about Sweden now, at least it's on the screen, but my experience with working with the US and US-based organizations is that they are exceedingly good at finding the politicians, the parents, and they are sometimes so heavily invested in that it's difficult to discuss with other organizations that are working with CPAP. And they have such a huge drive to implement and to get their products out. So what's your, maybe you don't have the same experience, but the US-based organizations, like we've seen Adara, Path, Rise here on the screen, they have a very different way of motivating what they're doing. But we're motivated mainly by research and grants. They're motivated by their funders, which are quite often parents, and I find their culture slightly different than the Scandinavian. So if anyone can do a reflection on how to collaborate with US, because that's where a lot of the money and the drive is, I would be grateful for a comment on that.
We take all the questions, then we take a final round, and then it was Ola, and then
Okay, first I just have to comment on the Jens. It was wonderful, and there was a lot of people on all the global health meetings. But one of the presidents, she's the president of the European Parental Organization, EFCNI, and I think that was such a heavy importance in that meeting, because we saw a lot of skin to skin, and there was a very wide program. So that's once again we have to find those parents. And I wrote a question in the Menti, which was: should we in Sweden accept that we need to think more like the US, that we have private funders instead of the government? The government is closing down, and we have a bank, my bank. It's just for this year, it has a revenue of $4 billion. There is a lot of companies, and we have all these really rich people now in Sweden. We are not Sweden anymore. Yeah, it's true. It's Norway is Sweden. No, but anyway, so should we try to do that? And then, of course, how do we talk with our funders? And because, influencers, the people who has the money and gets the money. Because now it's, I'm 58. I don't know. I have the idea, but I don't know how to communicate in a modern way, in the way I wished I could. So I think that's, we have also here to invite younger people and to have, all that, not just the experts, but the ones that are difficult to handle.
Thanks a lot. We take that with us, how to get the private sector into this. Yeah, 2 more questions.
Yes, thank you. First of all, I'd just like to thank you for all the really nice discussions, and also add that the researchers also have the responsibility to work with clinicians that are not researchers, and the clinical collaborations are the tools to sustain, to keep sustainability, I think. And I just want to mention a short example of that with NGO that some of us in this room is working with, Pediatric Health Initiative, where we have clinical collaborations for long-term work, where we also have engaged Swedish politicians from both sides of the parties. So there are actually examples of that, where the politicians are in the steering committee. But my question is something else, and that's something that we might discuss later today, how we can promote smoother integrations of new technology into low-income countries. And if we could have some kind of a fostering international corporations that can help overcome the barriers to actually take new products that are not already in that country, because we know it's really hard to get that little easy piece of plastic into this country that you are working with. So that is something I really would like to hear your thoughts about. Thank you.
Great. And then the final question, and then we move back to the panel. A lot of good and important questions and comments.
Thank you very much. Ultimately, I got it. Thank you. My first is no question, or maybe because I look at the diagonal part, because I'm working for last 20 years from SNL when he started in 2000 with Gates Foundation in Bangladesh. So I want to keep from the research to policy level. So I look at this diagonal part in different perspective. That the one part is pediatrician or neonatologist, whatever, and another part I would like to include the gynecologist and midwives and others, nurses, and in below the program managers from the and donors and other stakeholders, what we call. But in your journal, but it seems even today there is no gynecologist. There is no, because without gynecologists, nursing, midwives, it would be very difficult to ensure the delivery part at least, even postnatal. Because maybe Professor Joylon know our Projanma project, where we show in 2008 that we can prevent 36% neonatal infection only with the home care. So if we ensure the parents, what we discussed, the parents and mother. So there is some experience what we gathered from the low and middle income country. Maybe it's essential for in the developed country. So I would like to look at the Sweden, because now I'm in Sweden. I worked for USAID and DFID earlier, and now in the Uppsala University as a researcher, now senior lecturer, I'm teaching. I have CV courses. What I'm thinking, the gaps in Sweden, then SIDA, they're working in different countries. There is a gap between the researcher, those who are working locally with the SIDA fund, even Swedish Research Council fund, but there is no integration between them. So if SIDA do not talk about their research, what they're funding, even I talked to our, when I was in Karolinska doing PhD, I discussed with our coordinator, international coordinator. Do you know what is, who is ICD Derby? Where is it? Because in 124 institutions, ICD Derby was not listed. But in Sweden, last 35 years, Sweden is funding ICD Derby, International Research Organization, as a co-funder. I think it's almost $1 billion the last 35 years. So that gaps is that their integration, not only politician, or we talk with the politician, but we have to think about integration between the researcher and donors, as well as the politician, because donors are our main stakeholder to contact between the low and middle income country and Sweden. So they have to talk about us, what we are doing, why we are spending money in Bangladesh or in other country. If they do not discuss with that issues, and politician will not show any interest. Because I told even sometimes that this is Swedish money where we showed that toxic metal exposure like arsenic, cadmium has an impact on child growth and development. But unfortunately in Swedish government, Swedish clinicians don't know.
Thanks so much. So now we have very, very quick, 30 seconds. I'm sorry, we need to finish.
It's a very specific question for Agnes and Ylva. I love the pictures about the family-centered care, but the Godling family in the same bed, but it's also risky for infections, isn't it? So my question is there any protocol to follow to maybe lower that?
So thanks so much. So a very specific question to you, Agnes, about the risk of infections, and then to all of you, looking at the US, both how we work with the US in different ways in getting parents involved and also with the private financing, and then how to introduce new technology in low-income countries, and then how to get this connection between implementers, for example, Swedish SIDA, and researchers, that it's sometimes that even working in the same country, but they don't know what's happening. So a lot to the final round of comments. But first back, is it dangerous? Do you get more infections?
I'm so happy that you asked the question because I need to quote Vivi, my colleague who loves bugs, and I love bugs as well, but we need them. We live together with the bugs, but we need the right bugs. So babies are supposed to be colonized with their parents' bugs, really. And I'm really much more afraid of the other bugs in the NICU environment. So what I see when I come to units where it's a bit more crowded, more babies, less parents, is that they share beds, they share incubators, they are handled by a large number of NICU nurses and doctors, and I think that's more dangerous in terms of infections. So I think the mother's flora is not what's threatening the child in terms of infections. And we are actually in the middle of conducting a register study about that in Sweden. So hopefully that can teach us more.
Your reduced infections, didn't you?
Yeah.
So
So from the ICMC trial that we mentioned, we also looked at invasive infections in the children who were exposed to immediate kangaroo mother care and those in conventional care. And the numbers of invasive infections in the ICMC group was lower, actually. So, yeah, it's beginning to be more and more studied.
Thanks a lot for the question. And now we all have the answer. We can share that here in Sweden and with other countries. Diane, you had a lot of questions. Which one would you like to take?
Yeah, I want to contribute to the question about the US because I worked a lot with USAID, I worked with UK, and I think the system here is very different. And I don't know about the flexibility of the laws governing institutions like Karolinska, but I don't think you need the US. You don't need their money. You have enough money here. But I think the issue is the laws, how these institutions are governed, and the level of flexibilities. Because I believe, for example, by having a small piece of Karolinska in Africa, you would make a lot of money, you would make a lot of impact on lives of people, and you would also gain a lot. Yeah, because when I look at the difficulties African students have to come train here, even to get a visa to come here, it's a headache. I can tell you it's a headache. And I think if these laws were flexible, you have this flexibility and authority to change and to have a piece of Karolinska in Africa, like we have Coventry University in Rwanda, we have a piece of Harvard University in Rwanda, we have Carnegie Mellon University in Rwanda, and all Africans benefit because to come to Rwanda you don't need a visa. You just come in and you get your visa upon arrival at the airport, and it's cheaper to live in Rwanda than to live here. And the weather is fantastic. And the coffee. So I think, and the people, I really think, I think you can do that. When I was appointed ambassador in the Nordic countries, I said, wow, as a medical doctor, as a former minister, I'll bring a lot to my country. But it's not easy. It's not easy. So my question is, what does it take to change these laws? What does it take for Karolinska to think like a business, to be business oriented? Because you don't need this government money. If you come to Rwanda, for example, you get the land, you get the people, we are a young generation, we have, Africa is a young continent. I will give you another example. Recently, we inaugurated a big center established by a French surgeon, very, very known, Professor Maresco. He established in Rwanda a center for the whole continent of Africa. And it's a center for minimally invasive. So Africans, Western young doctors from the western part of the world, they will come to train in Rwanda. And we'll have professors coming from all over the places to train them. He will make money. It's not a charity.
That's
but
great.
He will make money out of helping a huge number of people, and very easily. So we provide them with the land. The government of Rwanda contributed to the infrastructure, and he brought equipment and the brand and human resources and the maintenance of this equipment. So this is a win-win project. Why don't you do this?
We take that with us, a small piece of Karolinska or other universities in Africa. I think that's also some of the take-home messages that we do. Joy, a final quick question from your side. You had a lot of questions or something else. What you would like to finalize with?
Yeah, I mean, I think coming back to this question on how do we interact with other funders, I think if we're going to make a big change in the world, we have to look to see where the money comes from. And we shouldn't take money from places where there funding who funds what and why, where their motivation is something that will subvert the final product. I'm not sure what you're thinking of with rice, because all the money that rice had came from USAID, from Grand Challenges actually, and now comes from 3 foundations. So that it's not coming from private funders. I think it links to what Vivi was asking about, how do we sustain? Because in the end, if you're going to sustain, it isn't charity that sustains things. It either has to, who's the payer? The payer has to either be the government, out of people's pockets, which I think Stefan showed was bad. The worst is Nigeria. 75% of funding is paid for by poor people's pockets. I was in a neonatal unit last October where I sat down and cried because there was a whole bay of babies who couldn't go home because their mothers couldn't pay. So we have to ask, you know, who's the payer going to be? The payer is either going to be the government, poor people, some sort of community fund insurance, or business. And if you can have business that's not for-profit model, particularly for small markets, I mean, that's the problem for caffeine, it's a small market. Most neonatal devices are still a small market. So you need some disruptive force. So for example, the middle person for devices in Kenya, Hatch, is a not-for-profit with funding from foundations to try and disrupt the business model. So, you know, most of us are clinicians or researchers. We're not the business people. But if we want things to sustain, we have to understand and work with business people. And business people, at the end of the day, if they do things not for profit, need some model that works where other people subsidize it, or they need a marginal profit. So, you know, if we're getting funding from the Swedish government here and the Swedish government's going to cut their funding, we have to say, how are we going to do things but still not compromise ourselves? And then who's going to be the payer in the long term so it's sustained? So it's really critical, because what I see is I came from a very idealistic, you know, all industry is bad, we shouldn't talk to them. But at the end of the day, it's industry that are the big payers, as you know, Ulla has said. So we need to be smart. We shouldn't take money from industry that means the end purpose is not gained. But there are people in industry who will do that. The Group B strep maternal immunization from Denmark is from an industry partner. Man, they're amazing. Like, I've learned so much from them. You know, so we need to not just say everybody is terrible in industry, but we need to also not say they're all great, we'll take everything from them. So we need to be wise, I think.
Thanks a lot, Joy, and I think that's important to find that balance.
Yeah.
Ashish, the final comment.
Yeah, so first of all, I would like to give a round of applause to Martin and you for his strategy leadership, because I think for the first time ever, we have come together on doing this, and also Olivia and the management team. So I think this is for all your work. And as I said, this shouldn't be a one-off event or moment, but a momentum, a movement that we take forward. And I hope that you will have a call for action. And I think one call for action should be that we invite more diverse group next year to such forums, because I think this is as we have created a critical mass, if you can continue to harness this one, then you will create a second generation of leaders and more generation, as Joy has created a lot of champions in her lifetime. So I think that should be the process of doing it. And as rightly mentioned, that until and unless we diversify, our narrative is still remaining within us. We should share our narrative to a large group of audience. And this is a STEAMed group with wise people around. So I think these wise wisdom should be not within the books of journals, but into their own daily discussions in the dinner time or in the tables. Yeah.
Thank you so much, Ashish. So just to summarize, this is difficult to summarize an hour like this, but just to say that, again, that we continue the research, we work together, and that Sweden, it's too small that we all work in silos. We need to work together much more, and I think this was a very good start. And then that we work with the parents, with the parliamentarians, and the people power, the 4 Ps, we bring them forward. And then that we're not afraid, we're not naive if we work with industry, but we need to find alternative funding. And to learn from the US, not to copy it, because I don't think, and it seems like you don't think everything is perfect in the US, but to learn from others. We will not survive, we cannot contribute as we can if we just continue and believe that we do it the same way as we have done for the last 20 years. It will not work. We need to find new ways. And how do we do that? And I think this panel was a starting point for that. And I learned a lot from all the four of you. And I also learned what to say when someone asks if it's not dangerous from an infectious perspective. And now I have some key references, which is always nice to base it on science and not just what you think. So Agnes, Diane, Joy, and Ashish, thank you so much, and thanks for everybody for a great discussion. And now I will hand over to Olivia and Morten again. But first, a big applaud. Thank you.
Yes, and thank you also, of course, to Tobias, who managed this discussion perfectly. Thank you. And we have had a fantastic morning, I think. It's not morning anymore, but day, I would say. And we would like to thank all of you for participating, because we are doing this together, of course. And all of you who presented your work or your ideas. Also, big thank you to you. And we made a donation of vaccines from all of us to UNICEF.
Mm. I think 15 vaccine packages. I'm not sure exactly how many vaccines that are, but...
Then we also have some sponsors that we need to mention coming to funders. We got money from Karolinska and UNICEF Sweden. And it's their contribution that made this seminar possible. So thank you.
And last, we want to thank the organizing team for their hard work. And I'm just going to mention everyone. Agnes, Ashish, Nicholas Pejovic, Susanna Myrnetshög, Johan Berg, Ola Andersson, and Tobias Alfvén, Karin Strömstedt at UNICEF, and Olivia, and myself. Yes. So with that, it's time to end this morning's session. We have, for those who have pre-registered, we have workshop discussions after the lunch, and you can see the group participants on the. There is a little paper on the whiteboard there, and I've also emailed everyone yesterday with group participation, and we start in half an hour, something like that. We discuss outside. For everyone else, I hope you enjoyed this this morning, and hope to see you at future events or different global health sessions. Thank you.